All right, so welcome to this presentation focused on IBD clinical research hosted by the Crohn's and Colitis Foundation. We're pleased to offer education and other helpful information to those living with IBD. My name is Brooke Rezvani. I'm a patient education intern at the foundation and currently a senior at New York University, and I major in public health as well as psychology. I'm really excited to be joined today by Dr. Elizabeth Squirell, a researcher in the gastroenterology division at the Department of Medicine at Queen's University. Elizabeth is the primary author of a paper titled Pregnant Pause, Not for IBD Care, a single tertiary care center prospective cohort study affirming IBD management in pregnancy. And I'll be asking Elizabeth questions about her research today. Elizabeth, would you like to introduce yourself?
Yeah, it's a pleasure to be here today. So I'm currently a researcher and a practicing gastroenterologist at Queen's University in Kingston, Ontario. But this research and the paper that we're talking about today actually came out of some of the time that I spent in Vancouver in British Columbia. The group there was where I actually did my inflammatory bowel disease fellowship. So I've had the pleasure of training actually across Canada. I'm originally from Western Canada in Alberta, and I did some of my training as far east as Newfoundland, and then ended up back in Vancouver for my inflammatory bowel disease fellowship, where a lot of this research was completed. I will say I finished writing it up once I moved back to Kingston. But now I'm settled here in Kingston for hopefully the long haul. I don't know how familiar the audience will be with Canada, but it is a very big country. So I'm pretty proud to say that I've had training and had the opportunity to live coast to coast here, which is a lot of driving when I moved.
Well, amazing. We're so excited to have you. Just before we get started, I'm going to go over a few quick pieces of housekeeping for any viewers. The information provided during this presentation is meant for educational purposes only and should not replace any advice you receive from your gastroenterologist or primary care provider. If you have questions about your specific care, please reach out to your healthcare provider, but the Crohn's and Colitis Foundation's IBD Help Center can offer support and information if you have any questions about Crohn's disease or ulcerative colitis. You can reach us by calling 888-MY-GUT-PAIN or emailing info@crohnscolitisfoundation.org. You can also access information about research and clinical trials on our website. So with that being said, let's get started. So to start, could you just explain an overview of this study?
Yeah. So our study was it was a prospective cohort study that really looked at the data compiled over a 6-year period in our tertiary care center in British Columbia. So this was a study that looked at 287 women throughout 291 pregnancies. So this was all of the pregnancies that we followed. There were more patients that had originally been enrolled with preconception counseling, but that 287 women are the number of women who had pregnancies throughout that time period in our center. The goal with this study was really to meticulously track several key areas from preconception all the way to the postpartum period. And the things that we wanted to look at were disease activity. So we really wanted to map out both how Crohn's disease and ulcerative colitis behaved during each trimester, how we measured it, how the activity behaved both with clinical symptoms, so how you're actually feeling throughout pregnancy, but also with biochemical markers, so blood work with stool tests, and if somebody had to have like an ultrasound or an MRI or an endoscopy throughout pregnancy, then including those as well. For most of the patients, they didn't need scopes throughout pregnancy, thankfully. So for most of those markers, we were using things like clinical scores, like the Harvey-Bradshaw Index or the Mayo score, which are some scores that we use to collect information. And then we also really wanted to look at medication use. So we tracked medications, what medications the patients were on, what switches they made, because at the start of this study, the general practice was to hold the biologic medications in the 3rd trimester of pregnancy, close to delivery. And that was at the time based on a little bit of lack of comfort and based on the fact that we didn't have the knowledge that we have now because of studies like this. that if the biologic could cross the placenta, baby could be exposed to the biologic. Are we putting baby at risk by having it continue in the third trimester? And thankfully, what's been found throughout other studies before ours was that really that's not a significant risk. And so as early in the study, we had patients who were holding that medication in the third trimester, but that changed as we went forward. And so it was a nice kind of highlight of our study that practice changed a little bit, but it was all a very uniform practice, if that makes any sense.
Yeah.
We also then wanted to look at all the maternal and the neonatal outcomes, all of them that we could. That's a big thing to ask, but we documented everything from the live birth rate, the mode of delivery. We looked at complications like gestational hypertension, preeclampsia, preterm birth, so early deliveries, or babies that were born too small for gestational age. And we specifically looked at things that have previously been associated with inflammatory bowel disease or thought to be associated with inflammatory bowel disease. So essentially what we wanted to do with this was create a really detailed and longitudinal picture of the interplay between IBD, what its modern treatment is, and then pregnancy outcomes in a setting where patients could receive a really proactive and guideline-based care with our kind of individual or single center multidisciplinary team. And the goal with it was to review the safety of current management as well as you can in this type of study, and identify any patterns that we could use in practice down the road to help care for these women throughout pregnancies and the little lives that they're creating.
Okay, amazing. And how did this study specifically come about for you and your team? Is there anything specific which inspired it, or was it more kind of just like what you talked about, wanting to improve pregnancy in women with IBD?
Yeah, I think a little bit of both. Yvette Liang, who is the senior author on this paper, was really the driving force behind this study. So when she moved to Vancouver, she started the IBD and pregnancy clinic. And this was in close collaboration with the maternal fetal medicine team in Vancouver. And that clinic still runs as the primary leads in that clinic are Dr. Liang and Dr. Liz Joa, who's also on the study. They really had this vision at the time to create this database and to be able to apply what we're objectively finding with the data to then further refine practice. And this, I think, really for them came from the fact that we were seeing overwhelmingly positive outcomes for women with inflammatory bowel disease throughout pregnancies. Their pregnancies were successful, their babies were healthy, but there's this persistent fear, and historical data kind of paints a little bit of a scary picture sometimes. Sometimes older studies had suggestions that there might have been higher rates of issues. But also there's just, I find pregnancy is it's a unique period in someone's life. And for some reason during pregnancy, everybody and their neighbor feels that they get to have some input on somebody's life and body. And I think it comes from a really well-intentioned place, but it ends up with there being a lot of information out there, and it's really hard for women to find what the accurate information is. And so I think this is really what drove that area of kind of looking into how can we provide our patients with evidence-based, informed, how can we help them make that informed decision when it's hard to study things in pregnancy. And so just using what we were already doing in practice and studying that, I think was how they came about that answer. And it really, a lot of the questions we were asking came from questions from patients. So what are my chances of a flare? When might a flare happen? What will this medication effect have on my baby? I think that really drove a lot of what we wanted to be able to translate into clinical practice.
Amazing. So kind of diving deeper into the study, could you explain what a tertiary care setting is and why you chose to conduct this study in that setting?
Yeah, so that's a very good question. It's a word that we throw around a lot in research of primary care, tertiary care, secondary care, tertiary care. a tertiary care setting is essentially a specialized setting. It's a referral setting. So it provides the highest level of advanced medical care, typically with referral. So you're not just walking in from, like, you see a sign on the street and you walk in and say, "Hi, I'm here for an appointment." It is based on referrals and more as kind of like a hub for more complex cases. For IBD, what this means is that we see patients with more severe disease, more refractory disease, sometimes with extensive surgical histories, and often those who require advanced therapies like biologics. In our practice in British Columbia, there were a lot of patients who were referred to the IBD and pregnancy clinic specifically from other gastroenterologists. So they're already followed by a specialist, but that they were referred for preconception counseling in the IBD and pregnancy clinic. And then from there, they were followed throughout their pregnancy into the postpartum period, and then actually sent back to their primary gastroenterologist for continued care down the road. Sometimes they came back for further pregnancies, and sometimes they just went to the doctor closer to home for the, I guess, remaining time period, rest of their life, I would say, but it's not been that long since the study was done. We specifically chose to focus the study in the tertiary care setting, in part because it was where we worked, so it was easier to do, but also because I think this gives us a lot of information of this kind of concentration of slightly higher risk patients. So this setting naturally concentrates the population where the stakes are, I guess, the highest, where there may be more active disease. They're also more likely to be on biologic medications. And so if we can demonstrate that even women with more complex IBD can have successful pregnancies with outcomes similar to the general population, I think it sends a really powerful message about what we can achieve with optimal care in general in the IBD population. The other thing that it allowed us to do was actually standardize the approach. So we had a multidisciplinary care team within our clinic. We had patients following this fairly standardized clinical care pathway. It's hard to perfectly standardize things in medicine because bodies behave as they want to. But all of these patients were seen by a team that involved their IBD specialist, maternal fetal medicine, and then an IBD nurse as well. And we had the availability of a dietitian if needed. So this integrated approach allowed for some advantages especially in research, because it kind of minimizes the confounding variables of how, is it just differences in practice or differences in approach that are contributing to differences rather than differences in the disease. The one thing I will add that it potentially limits a little bit because of the tertiary care setting is that it does probably limit how generalizable this is to everybody, because we're following a pretty kind of standard approach to things in a certain setting with certain resources. And so is this definitely generalizable to somebody who doesn't have kind of that same pathway or that same setup, or who doesn't have as active or severe of disease? It's hard to definitely say that. So it's very much still an observational type study.
Okay, amazing. And could you talk a little bit about the results of this study?
Yeah, so the results of this study, I have a little cheat sheet for myself in the background because I want to make sure I'm not forgetting any numbers.
Yeah, no worries.
Overall, I found that the results of our study were very reassuring for pregnancy outcomes, even in this kind of slightly higher risk group of patients. I'd summarize that the key findings would be that there were excellent overall outcomes. And this emphasizes that this proactive management approach works. Our cohort had a 92.7% live birth rate. So this includes women that were enrolled pre-conception, had an early pregnancy, and then potentially an early pregnancy loss. And so that 92.7% live birth rate is kind of very much on par with the general population. The rates of preterm delivery were quite reassuring at 6.7%, which is lower than the rates in many settings in the general population. And the rates of infants born I can't speak, small for gestational age, was found to be fairly low at 7%. And this is comparable or even slightly better than the rate in the general population. So this is really a message of reassurance in this realm. There was, because one of the things we really wanted to look at was how the disease behaved throughout pregnancy. And there was a clear sign that there was a pattern of flaring disease in ulcerative colitis. So this was something that we found and was probably actually our more striking finding in the study, that as you go through pregnancy, there was a higher rate of disease activity. It peaked in the second trimester with 37% of patients having IBD or ulcerative colitis flares throughout pregnancy. And then it did start to decrease a little bit, but obviously with that, we weren't just watching people, we were putting them onto medication and treating their flares. And so that decreases also with additional medication and treatment for the flares. The other things that we found, we looked also at, as I said, medication use. And so biologic safety was a really key thing that we wanted to look at. And this, I think, really echoes what's been seen in other studies, like the Piano study, which demonstrated that we had a stable use of biologics throughout pregnancy in our group. And it was not associated with adverse outcomes. It really strongly supports the modern guideline to maintain these essential therapies. And like I said, most of our patients, aside from in that first year or so of the study, continued the biologics throughout pregnancy and didn't hold any doses, didn't hold their third trimester dose. And so by doing this study in with such kind of granular detail, we were able to see that they got their doses in the third trimester, which was really important. The one thing that came out in looking at the biologics in pregnancy was there was a slight association with an increased risk of infection in babies in the first 6 months postpartum. This is a harder thing to measure, in part because there were such small numbers of infections. But it's really important to note that those infections were not severe infections. So there was overall in the first 6 months, there was 25% of infants who had been exposed to these medications had some sort of infection, whereas infants who were not exposed, it was only 6%. And the few things that I take out of that, because 25% seems like a very scary number, are that, one, they were not severe infections. The number of severe infections, we didn't see that same difference with. This is things like coughs, colds, runny noses, mild childhood infections. Some of them needed antibiotics, but when you're doing research like this, it's difficult to know if the reflex is to give antibiotics because the doctor knew the baby was exposed to that medication, right? So it's difficult to know kind of cause and effect in that area. And then the other thing that I think deserves a lot more research in that regard is that we had some loss to follow up in the postpartum period. And so women who had been exposed to biologics and whose child had an infection may have been more likely to follow up and report that infection to us. Whereas women who the baby had been exposed to a biologic, but then the baby did fine and had no infection, didn't need any antibiotics or anything like that, they may have been more in that loss to follow-up group. We tried to account for that with propensity score matching, but that's a challenging thing to account for when you have fewer outcomes. Hopefully that's a digestible way to understand that. Yeah, I think those are really the big things that came out of this study. There's, I guess, two more points that I'd really highlight in this study. One of them was that steroid use, when we're thinking about medications, it did seem to be correlated with a higher rate of preterm delivery. And so those patients who were on steroids there was an association with them having babies earlier, and earlier than is ideal. That has been a theme in other research as well. And it's very challenging to know if that is coming from the active disease rate, which it probably is, that women who have such active disease that they need a steroid medication,
Mhm.
that they have a higher rate of preterm delivery. But it is something that in those patients who need steroids in pregnancy, those are certainly patients that we want to have involved with maternal fetal medicine and have some closer monitoring of, and make sure that we're providing good care for those patients, and providing care for mom and baby. And then I think the last thing, because I've just thrown a lot of information here, the last thing that I will kind of add here that I found particularly interesting, and we might talk about it later in kind of room for further study, was that we didn't see a big difference in the rate of adverse outcomes. So, preterm delivery, small for gestational age babies, maternal adverse outcomes like blood pressure issues, things like that. We didn't see a big difference between Crohn's disease and ulcerative colitis in those outcomes. But the interesting thing that comes from that to me is that we did see that difference in disease activity in those with ulcerative colitis. And we know from a lot of other research that if you have more active disease in pregnancy, you're more likely to have those adverse outcomes. And so if Crohn's disease was less likely to have active disease, why would it have a similar rate of those adverse outcomes, if that makes any sense?
Mhm.
And that's something that I really took out of this study, is that there may be something that we're either not understanding with measuring disease activity during pregnancy with Crohn's disease specifically, or that our activity scores are missing. And I think we need to delve more into that. Is are we truly capturing that active disease rate in Crohn's disease in pregnancy with the scores that we currently use? Or is there something else that, if we did a bigger study, would we find different information? Or if we, is there something kind of more just about Crohn's disease that increases that rate? And I think other research would suggest no,
Mhm.
but it's an area that I think definitely needs more information. And it was something that really triggered me to think more about Crohn's disease specifically and how we're measuring the activity.
Yeah, that's amazing. That's definitely very helpful. I did want to circle back to what you said about the potential correlation between the steroid medications and preterm births. So it's noted that the pregnancy-related changes in the gut microbiome and the mucosal immune system do have the potential to largely impact pregnancy outcomes in IBD patients. So given that Lactobacillus bacteria has been found to act as a protective factor for preterm births or low birth weight births, in your opinion, could that improve pregnancy outcomes for women with IBD, and maybe potentially kind of combat some of that correlation with steroid medication usage?
Yeah, and so I think it's a good question, and it certainly comes out of some research that's coming from the general pregnant population, and less so I guess kind of overlapping research that comes from the general pregnant population, but then also research in the microbiome and IBD. The gut microbiome is, I think, certainly a key player in inflammatory conditions. Sorry. And I think we're really just beginning to understand its role. It's a very, very complex thing, and it's a challenging thing to research. And I have some colleagues who focus a lot of research on the gut microbiome, and I don't envy their job, because it is a hard thing to research and wrap your head around. But there is the idea that we could leverage a specific bacterial strains like lactobacillus, and use that to kind of regulate the dysbiosis that is associated with poor outcomes in some cases. Um, we know that IBD is characterized by kind of dysbiosis for like this dysregulation of the kind of good and the bad bacteria. And we also know pregnancy itself induces shifts in the maternal immune system and in the microbiome, the good and the bacteria in the bowel. And so it's logical to think that in women with IBD, this changes the kind of interaction of the underlying dysbiosis and could promote that flare of disease, which is suggested then by the flare rate that we see in ulcerative colitis in our study. So that logically leads to the next question of, could targeting specific probiotic therapy be helpful? And in theory, I think yes. I think though right now we're still at that in theory time. By introducing those beneficial bacteria, we might be able to stabilize the gut microbial community and kind of bolster that gut barrier, modulate the immune system or the immune response in a way that might protect against both flares. And then with the research around preterm delivery, 2 birds in 1 stone, decrease flare rate and decrease preterm birth rate. But I think we have to be really clear that right now the academic consensus is still very much evolving for the microbiome, for probiotics. Most of the studies around probiotics are pretty underpowered right now. They're pretty small groups, and the effects are really strain specific. So you're studying one probiotic, and then the probiotic that's available on the shelf to the patient is not super well regulated, hard to know what to buy, hard to keep it stable. So it's a really challenging thing to kind of take from bench science to practical use. So I think it's a really promising concept, but I think it's a field I'll be watching closely, and I'm hopeful that there will be more in that area as we go on.
Yeah, amazing. It definitely sounds like there might be some potential there. I'm curious if you found that there was any kind of reluctance of women to participate in your study due to the potential for pregnancy, which could lead to other side effects like fatigue or other things that may not want them to be active in a study.
Yeah, so I think that we were lucky in the group that we had, but we also, I think pregnancy is an exhausting time period. But I've been consistently impressed by patients' willingness to engage in research and to kind of further the knowledge base that we have. We did try to minimize the impact that engaging in research would have in our study. We already have a pretty kind of, I want to say well-oiled, but sometimes it's not, but well-oiled clinic where most of the data that we were collecting, most of this information was a part of our standardized protocol just for providing care for these patients. And so by participating in the research, they did have a few extra phone calls, but they didn't have a lot of extra, they didn't have extra blood work to do. They didn't have extra stool tests to do. We were trying not to put an extra burden on people. With that being said, the engagement in the phone calls, the engagement in working with the researchers was really high. And I think that speaks to the population of pregnant women and the motivation that they have to kind of provide more knowledge for other people out there who may be going through a pregnancy in the future, and to kind of help do a small part in kind of providing that information. And I think that it's easy to underestimate how much a pregnant person will be willing to go through to help further that kind of knowledge base. But I've been really impressed with our group and how much they were just able to give their time. And yeah, they were all very curious also when we were kind of doing the final follow-up calls about, okay, when is this information going to be available? And so I'm pleased that we're doing this podcast today to provide a little bit more digestible information for people.
Yeah, for sure. That's amazing. And then kind of going off that, how would you navigate the recruitment of pregnant women into research studies?
Yeah, so that's I don't know if I'll have the end solution to that.
Yeah.
The I think that again, this is a group that is afforded some special protection in research ethics, and I think that's an important special protection in research ethics that this is kind of a group that's considered a slightly vulnerable population, and we want to make sure that we're doing right by pregnant patients, and it requires that more thoughtful and empathetic and patient-centered approach to research. And I think that there's a couple strategies. We tried to use some of these strategies of integrating research into the clinical care pathway. So already having that clinical care pathway, trying to get the information that we can out of the practice that we already use and not putting kind of an undue extra burden on people, trying to minimize extra travel time, things like that. I think that the using kind of a trusted provider and a trusted clinic setup is an important thing. It's a challenging thing to navigate. You want to make sure that somebody still feels that they can say no to a research study, and so making it clear that there is that kind of arm's length with the researcher and the project, and that their care is not ever going to be compromised by them not participating in a research study. But also knowing that somebody that they know and work with and have a relationship with, like their doctor is kind of on board with this study, and helping with the recruitment in some cases can be helpful. That's a little bit of a kind of weighing out the risks and benefits of that part of it. And then I think it's also making sure that you're as flexible as possible and making this as easy of a process as possible, especially when you're trying to do any postpartum research. As soon as somebody has that sleep deprivation, they have a new baby, they have, they're focusing on they've just grown a new human, but now they're focusing on keeping it alive and fed while they're sleep deprived. And so if they're not submitting their fecal calprotectin and they're forgetting to do their stool test, trying to make sure that this is as kind of flexible and as easy of a process as possible for them, I think is important. And I found that the postpartum period was actually probably the hardest. But throughout pregnancy, I think often I think the sleep deprivation is a little less real throughout pregnancy, and then it's postpartum, it's a little more challenging.
Yeah, for sure. Okay, and I'm kind of wondering, what are the next steps of this work beyond further longitudinal research? Do you and your team maybe have any more studies with pregnant women as participants planned, or where do you see that going?
Yeah, so we were actually just having a meeting about this the other day. There is a little bit that kind of came out of the data that we already have that I think will further contribute. This was a big study that had a lot of information in it, and so I didn't want to add a ton more to it when we were writing it up. One of the things that we did look at was the rate of C-section delivery in our population. And that rate was fairly similar to the background rate in the population, but it was a little bit higher. And it wasn't fully explained by things like perianal disease, which would definitely indicate a C-section delivery. And that's one of the important things I emphasize to patients is that, historically, a lot of women with any form of IBD were told to have a C-section. And that's not the current recommendations. The current recommendations would be only patients who've had significant perianal disease with active kind of fistulas, or who've had what's called a J pouch, or have had their colon removed and have an IPAA. Those women would be recommended to have a C-section, but otherwise it's really kind of a case-by-case scenario, and their IBD shouldn't, in most cases, be the thing making the decision about a C-section. And we did, though, find that even apart from women with perianal disease and IPAAs, we did have a slightly higher rate of C-section delivery in our population, and that has been seen in previous research in IBD as well. So one of the things that we looked at as well was actually the method of delivery that the women plan to have at the start of their pregnancy.
Mm-hmm.
And we haven't been able to kind of go through and analyze that data in great detail yet. But that's something that I'm hoping to look at, is kind of what were those factors? Like, did a lot more women just want to have C-sections? Because if that's the
Mm-hmm.
case, then great. But if it's something that came from something a little bit misguided, then I think it gives us a lot more information, right? So
Mm-hmm.
that is an area that I think um, is important to look at, and something that we have the data to look at in the future. The other things that the two other things that I'm kind of really interested in looking at, one of them is I think particularly relevant in, unfortunately, in 2025, but is the vaccination in our patients. I don't know if this is universal practice across North America, but in Canada, it is universal practice to check measles, mumps, rubella titers during pregnancy, but you
Okay.
can't do the MMR vaccine during pregnancy. And
Mm-hmm.
it's challenging to do it on an immune suppressed individual. It wouldn't be recommended for somebody on biologics. So you can look at whether they've had adequate vaccination, or had adequate kind of immune response to the vaccination, and then look at whether they'd be provided with that kind of protection after pregnancy, or whether they'd be passing it to baby. And so that's something that I think looking at that data would be very interesting and unfortunately relevant in 2025. And then the very last thing that I'll say, aside from just kind of following these up long term and looking at the long term outcomes for these kids, would also be, actually, I think I touched on it a little bit before, but looking at how we're measuring disease activity in inflammatory bowel disease, and if there's better ways that we could be measuring it, if there are other scores that we could be using, because it's a hard thing to measure. Some of the scores we use look at, like, one of the things that we ask on the Crohn's disease activity index are you feeling below par? A lot of women in third trimester of pregnancy are probably feeling slightly below average.
Yeah,
Um,
of
and
course.
so that's a hard thing to kind of incorporate into a score. And so we're using these modified scores that weren't made for pregnancy. And so is there a better way to be looking at that? Is there more objective ways to be looking at it that aren't maybe stool tests that are a really big pain to bring in? One of the things that I see potentially being in the future, even more in pregnancy, is actually using ultrasound for the bowel.
Mhm.
And that's something that I know the International Bowel Ultrasound Group in Inflammatory Bowel Disease has been trying to incorporate more research in pregnancy and more use in pregnancy. And I think that's going to have a really valuable role as time goes on. But I think, again, getting the kind of the data to really empower both physicians and patients,
Mhm.
that these are the right things to be doing, is a really important thing.
Yeah, that's amazing, and it's definitely very important and very relevant to today's world as well. Is there anything else you'd want to share for any patients who have IBD and are pregnant or are hoping to be and may want to participate in research but aren't completely sure?
Yeah, so I think that one, it's not an intuitive thing to tell your bowel doctor about your pregnancy plans,
Mhm.
but I think it's a really important thing. And that's something that when I first meet somebody in my IBD clinic, I talk to them about what their family planning is. And so if any individual is wanting to pursue family planning and pursue a pregnancy, having that conversation with their gastroenterologist, well, it feels weird to go in to talk about your bowel movements and be like, oh, also, here's my pregnancy
Mhm.
planning. It's an important thing to make sure that you have all of the kind of all of the adequate planning from the bowel and the pregnancy perspective. So that just from a general perspective, just remember to actually talk to your gastroenterologist about your pregnancy planning, even though it sounds a little bit counterintuitive. The From a research perspective, because again, I've been very pleasantly surprised by the number of pregnant individuals who've been very willing to be a part of research. What I would say is ask your gastroenterologist, ask in your general clinic or your general vicinity if there is anything going on that you could take part in. But beyond that, across North America, the Piano study has continues to recruit. I'd have to actually look at whether patients can self-refer to the Piano study. I think that they may be able to, and looking into that. And so that's something that you can easily Google. I don't know if we'll be able to put a link or anything like that. But that's a really good way to get a little bit more kind of broad, high level data for improving our understanding of inflammatory bowel disease and pregnancy, and improving our understanding of kind of how to navigate life with this chronic condition.
Yeah, amazing. Well, that's all I have for you today. I just want to say thank you again so much for discussing your research with us. It's definitely been very helpful and very informative. Just to reiterate to any viewers watching, if you do have any questions about IBD and participating in research, including any clinical trials, please visit the Foundation's website at crohnscolitisfoundation.org and the Clinical Trials Community webpage. Again, you can also contact the Foundation's IBD Help Center by calling 1-888-MY-GUT-PAIN or emailing info@crohnscolitisfoundation.org. But as always, we recommend that you discuss any clinical trial of interest with your healthcare provider. Thank you for tuning in.